I'm going to speak about asthma. It is pediatric nursing, and I will explain some NCLEX question beside explanation. What is asthma? And what are the trigger, sign and symptom, and diagnosis? And finally, we will discuss about the medication and nursing intervention, family education, and complication of asthma. Let me explain one by one. So asthma is a chronic inflammatory disease or inflammatory disorder of airway. It is intermittent and reversible. Asthma is classified on basic of disease severity. Management include medication, environmental control of allergen, and child and family education. Environmental control of allergen, because allergen is a trigger materials. Family education means exercise, cold air, tobacco, smoking act as a trigger and increase the acute attack of asthma. In the picture, you can see the upper respiratory tract bifurcation and two lungs, we call airway. In the normal healthy person, the muscle is relaxed and we can see the normal lumen and normal amount of scanty mucus. But in case of asthma condition or acute asthma, we can see the muscle is tightening, constricted, not relaxed, and edema develop, excess mucus and lumen is getting narrow. Swollen the muscle, lining epithelium, excess mucus, and causes the so many complication of asthma. Here we go, the description. The allergic reaction in the airway caused by precipitating can result in immediate reaction with obstruction occurring, and it can result in late bronchial obstructive reaction. Mast cell release the histamine. So if a patient has a chronic inflammation and acute attack occur, the mast cell activated and mast cell release the histamine. And this histamine lead to bronchoconstriction, bronchospasm, and obstruction. And patient develop the asthma. Diagnosis is made in the basis of child symptoms, history, and physical exam, chest radiography, and laboratory test. Also, we also do the pulmonary function test. And we should find out what are the underlying trigger factor, precipitating trigger an asthma attack. Like allergen, cold, tobacco, smoke. When asthma, as I told you, asthma is a chronic inflammatory disease. But when acute attack or acute exacerbation of chronic asthma, we call status asthmaticus. is an acute asthma attack. The child displayed with distress and all despite vigorous treatment measure. And this is a medical emergency that can result in respiratory failure and death if not treated. In asthma status asthmaticus or acute asthma attack, patient present with wheezing, coughing, anxiety, chest tightness, shortness of breath, and patient use the accessories muscle. Before to go next, the sign and symptom of asthma, let me explain these two pictures. In this picture, showing the normal healthy lungs or respiratory tract, the relax the smooth muscle and alveoli inflect and no mucus lumen is bigger. But asthmaticus patient tightness or constricted the muscle in the tract, so much a lot of mucus, edematous lining epithelium. Also, alveoli is inflect, but they do not deflect, right? Also, residual air inside the alveoli. In second picture, we can see normal airway. It is asthma patient airway and the acute asthma. In relation to first one, the second one is narrower. This is airwaist and edematous the lining epithelium. Acute attack of asthma. What are the sign and symptom or data collection? Patient present with tachycardia or tachypnea, restlessness, wheezing, and nighttime coughing, common sign. Let me read it. Shortness of breath, dyspnea, wheezing, breathlessness, chest tightness, and productive cough. All of this condition lead to the anxiety or restlessness. Especially, particularly, patient complain of cough at the night. Okay, and also, if you see the patient, they use the accessories muscle, so intercostal retract here. Use the accessories muscle. Acute asthma attacked episode of progressively worsened shortness of breath, productive cough, wheezing, chest tightness, decreased expiratory airflow, secondary to bronchospasm, mucosal edema formation, mucus plugging, air is trapped behind occluded and narrow the airway, and hypoxia may occur. So when all of this condition lead to less oxygen to the tissue, oxygen deprivation, less oxygen in blood, we call hypoxemia. The acute attack with irritabilities, restlessness, patient complain headache, feeling of tired, chest tightness. Just before the attack, the child may present with itching localized at the front of the neck or over the upper part of the back. Why? because mast cell secrete histamine. What else? So acute attack respiratory symptom include the include the irritable non-productive cough caused by bronchial edema. Accumulate secretion stimulate the cough become rattling, or there is productive of ruddy clear sputum. The child experience retraction. In the first picture, we can see the ribs. In between two ribs, the muscle we called intercostal muscle. Intercostal muscle usually not participate in respiration because diaphragm is a major muscle. Sternocleidomastoid muscle helps. But when patient has a shortness of breath, body try to compensate. So accessory muscle participate in respiration. So we can see inward or outward bulging or inside growing, and this is we call retraction, intercostal muscle retraction. It indicate your patient is struggling for air, for oxygen. So if you put the stethoscope over the lungs auscultation, we can found the added sound like wheezing or ronchi or crackles. The child may be pale or flushed. Lips may have deep dark red color. It may progress to cyanosis because of obstruction in the respiratory system. The patient do not get enough oxygen. Tissue does not get enough oxygen, but demand of oxygen is increased. Supply is red, and patient develop cyanosis. So in this picture, we can see the lips area, bluish discoloration. Patient develop the cyanosis. And also here, restlessness, diaphoresis occur, and child speak in short, broken fades. Younger children assume the tripod sitting position like this because they're struggling for oxygen. But older child sit upright with the shoulder is hinged over positioning. Accessory muscle participate in breathing. If patient develop the asthma because of exercise, we call exercise induced attack. Cough, shortness of breath, chest pain, and or tightness, wheezing, right, or problem occurred during the exercise. Now, acute asthma attack, severe spasm or obstruction, breath sound and wheezing cannot be heard, and the cough is ineffective. Ventilatory failure and asphyxia, shortness of breath with air movement in the chest restricted to the point of absence the breath sound, we note it. So if your patient have a acute condition, we give them some medication that immediately relieve the condition. Usually we use bronchodilator. Right? In this picture, we can see the patient using salbutamol inhaler or ibohaler. We use metered doses inhaler. Now, here we go, the laboratory test to assist in diagnostic asthma. Pulmonary function test. 1. We use the spirometric testing access. Also peak expiratory flow rate measurement or bronchoprovocation testing. Or exercise challenge test, chest radiography may show hyper expansion of airway. If your patient has an acute asthma attack, what we could do? Assess the airway patency and respiratory status. Admin humidified oxygen by nasal cannula or face masks. Administer quick relief medication. Initiate an intravenous line. Prepare the child for a chest radiography. Prepare to obtain blood sample for determining arterial blood gas level analysis. Right? So, if our patient look like this, what we could do, right? So what are our intervention and what are the medication? First of all, let me talk about the medication. Quick relief or rescue medication used to treat the same symptoms and acute exacerbation. Like another is long-term control, means preventing medication. Acute condition, basically we use bronchodilator or anticholinergic medication. And long-term and prophylaxis, we use corticosteroid used to achieve and maintain the control of inflammation. Acute condition, we use also the nebulizer, metered dose inhaler may be used to administer medication. If the child has difficulty using MDI, MDI stands for metered dose inhaler. Medication can be administered by nebulizing. If MDI used to administer corticosteroid, we should use the spacer, and which prevent the yeast infection in the mouth, right? Like in a picture, we can see, and here it is called metered dose inhaler. So we should remove the cap here and hold the inhaler upright, and then we shake it and open the mouth, right? And hold the inhaler 1 or 2 inches from mouth or in the mouth, making a seal, and presses down metered dose inhaler, and then release the medication inside our mouth. After use the metered dose inhaler, it is better to hold the breath for 10 seconds and exhale slowly through the pursed lips. What else? If long-term control, we use corticosteroid, right? Corticosteroid like methylprednisolone or prednisone to decrease the airway inflammation. Anti-allergic medication to prevent an adverse response to exposure to allergen. Non-steroidal anti-inflammatory drugs for anti-inflammatory action. Long-acting beta-2 agonist for a long-acting bronchodilator. Short-acting, basically we use L-buterol for acute exacerbation and for use before exercise. Leukotrienes medication to prevent the bronchospasm and inflammatory cell infiltration. Monoclonal antibody blocks binding of immunoglobulin to mast cell to inhale inflammation. And sometimes we use quick relief medication. We call rescue medication. Short-acting beta-2 agonist for bronchodilation. As I told you, we use L-buterol for acute exacerbation before, or we use before exercise. Anticholinergics for relief of acute bronchospasm. Most common anticholinergics medication we use atropine or ipratropium bromide. Also systemic corticosteroid for inflammatory action to treat reversible airflow obstruction. Usually we use methylprednisolone or prednisone to decrease the airway inflammation. What else? So now we're going to talk about what are the other therapy we can use, like chest physiotherapy and allergy control. First of all, chest physiotherapy include the breathing exercise and physical training. Or chest physiotherapy that is increase the strength of respiratory muscle and produce more effective breathing pattern, right? So in this picture, lateral view, and second picture is anterior posterior view, we can see the technique of breathing, right? We call pursed lips breathing. Physical chest physiotherapy is not recommended during an acute exacerbation. Allergen control. The rest testing may be done to identify what are the underlying trigger materials. So we should avoid the known trigger like allergen. Reinforce the teaching the child and parents about the measure to prevent and reduce exposure to allergen like pollen allergy, dust allergy. Here showing precipitating trigger an acute asthma attack like allergen, pollen, air pollution, spore, dust, mold, antigen. Exposure to occupational irritation, some chemical substance, exercise, cold air, changing weather or temperature, hot to cold or cold to hot. Environmental change or cold and infection, animal dust, some medication like aspirin, non-steroidal anti-inflammatory drugs, beta blockers act as a trigger, act as a precipitating factor. Emotional condition like gastroesophageal reflux, some food, nut, milk, dairy product. Also endocrine factor, right? Next here, what are the home care? If your patient has an asthma, right? So if my patient got hospitalized with asthma, what are the nursing intervention or what are the teaching we could explain them? First of all, as I told, avoid the known trigger, give your patient or tell your patient for a high polar positioning, give them nebulizer, oxygen, antibiotics, or steroid. And sometimes we use prophylaxis medication like albuterol. Also, we monitor the peak flow meter. This is the green, you see, this is the peak flow meter. So we measure how well air move and out in the lungs. Let me read it. So reinforce the instruction to the family and measure the eliminate environmental allergen. Avoid extreme of environmental temperature. In cold temperature, instruct the child to breathe through the nose, not in the mouth. So inhale through the nose, but exhalation through the mouth. Avoid exposure to individual with a respiratory infection. So if you know somewhere somebody is infected, better to avoid them. Avoid the public place. Reinforce the instruction to the child and family how to recognize early symptom of asthma attack. Reinforce instruction to the child and family how to administer medication as prescribed. Reinforce the instruction to the child and family how to use nebulizer, meter dose inhaler, and peak expiratory flow meter. So this is the split expiratory meter. So reinforce the instruction to the child and family about the importance of home monitoring of the peak expiratory flow rate. A decrease the expiratory flow rate may indicate impending infection or acute exacerbation of chronic asthma. You can see this is the peak expiratory flow rate. There are three colors: red, green, and yellow, right? So we could educate the patient or teach three zone management or understanding. When patient put their mouth ear insert this device, if this indicator in a green layer, it means the peak expiratory flow rate is 80 to 100% of it is indicate normal. Asthma is well controlled. If we see the peak expiratory flow rate in yellow level, like this picture, indicator red one close to the yellow, it means 50 to 80% personal lungs capacity. Asthma is not stable, chance to get worse or chance to go better. It depends how you control. When we see the indicator in the red mark, it means the peak expiratory flow rate less than 50% of personal best. Asthma is not controlled. Asthma is severe and emergency care needed. It is very important to know. Then here, reinforce the instruction to the child in cleaning of device, use for inhaled medication. Otherwise, yeast infection can chance to occur. Encouraging adequate rest, enough sleep, and well-balanced food. Reinforce the instruction to the child in importance of adequate fluid intake too, and also enough fluid that is liquefied the secretion, right? So when patient use this device, like peak expiratory flow device, when patient know how to the understanding green, yellow, and red color, it alert the patient to control their asthma, or they see the symptom before attacked. So we have to instruct the patient. What we could instruct? Use at the same time each day. Ensure the marker, ensure the marker to the 0 level when they start, right? And also another NCLEX board asks a question, better to, when they do this, use this device, stand up, blow out as hard, as quick as possible. Perform 3 times and record the highest number. What next? Family teaching. Home care of asthma. Reinforce the instruction to the child, produce for respiratory treatment and exercise as prescribed. Encouraging the child to cough effectively, encouraging the parents to keep immobilization up to date. Also, annual influenza vaccine are recommended for child for 6 months of age or older. Inform other healthcare provider and school personnel of the asthma control. Allow the child to take control of self-care measure on base of is appropriate. So family education is very important. Like keep the child indoor during fluctuating the weather or when pollen count are high. And keep in mind, the asthma have some complication like status asthmaticus or airway obstruction, also chance to respiratory failure and need for intubation.